right, so the case. The case is a 25-year-old male. He came to us with a 2-week history of fever and with the rigors as well, fatigue and malaise, a headache, some vomiting, nausea and vomiting. Initially, actually had some small specks of bright red blood, but we think that wasn't the blood wasn't the dominant part. That's probably related to the platelets, which I'm going to show you in a second. And similarly, had some dysuria and macroscopic hematuria and some right upper quadrant pain. So fairly non-specific, but fever, rigors, headache, malaise, nausea, vomiting, and a little bit of bleeding. He's a Zimbabwe national. He hadn't traveled to Zim recently, though. Last he was there in 2018. We got some of this history only later, but I'm just going to go through the social history. So he had recent work in Barberton and Mpumalanga that was started about 2 months before admission, and he stayed there for about a month, and that ended about a month before he came into the admission. He worked there as an illegal gold miner. He wasn't part of the team that actually went underground to get the gold, but he was part of the team that washed the gold in the river, as they say. So it's, I guess, panning for it, right? You know, with the parts that were the parts that were brought up, the ore that was brought up. And you do the last part of it. He slept in a sort of makeshift shelter, really in the veld. Like this is properly rural. Like it's not like a brick shelter at all. This is just something in the middle of the veld, miles away from everything else, with very rudimentary things. I mean, his water was literally from the river that he was washing the gold in. He was bitten by every insect known to man. Definitely mosquitoes, definitely other insects, possibly including a tick. He said you might have seen a tick on one indication as well. And that's quite an interesting social history. He drinks alcohol every weekend, but otherwise not much alcohol. Can't get anywhere he is, which is probably one good reason. Not a smoker, no recreational drugs, and no pets or animal exposures. So when he came to see us, he was in trouble. Blood pressure was low, 90/52. It perked up a little bit with some fluid, but that was where he started. A pulse of 152, so very tachycardic. The SAT's a little bit low, but I think that was more just under perfusion. We don't actually think he had a respiratory problem. His blood gas was okay, and you'll see his X-ray was fine at the beginning, at least. Respiratory rate was 16, glucose of 9. He was slightly jaundiced, and his urine dipstick showed urobilinogen, also some blood and some trace leukocytes. And then an abdominal examination, he had hepatomegaly, and he was dull in trough space, but you couldn't palpate the spleen, but it was dull on that region, so somewhere in that region. And he was tender over where the liver was, so right up quadrant. No overt peritonism, just if you push on the liver, it's a bit swollen and tender. That was really most of what was found on the exam. Cardiovascularly was okay. Central nervous system was fine in the beginning, at least, and chest was also fine. So really just cardiovascular system, just these bounding hyperdynamic pulse because of where he was. Those are his bloods. So there's a lot on the page. I've highlighted the abnormal ones in red there. So he's a bit anemic in the beginning. Quite marked thrombocytopenia, though, platelets of 62. No fragments seen on the smear. And it was a true thrombocytopenia, no platelet clumping. His white cell diff is there, nothing fancy on that. CRP is up. He's HIV negative, done an ELISA test. Ferritin more than 2,000. And then there's UNE, he's a little bit off there. So the creatinine, there's 112, and with a raised urea, slightly low sodium. And you can see the LFT also slightly deranged. So bilirubin 51, total and conjugated 31. Slightly low albumin, ALT, AST both slightly up, although AST quite a lot more than ALT. And his INR is normal, so not really a DIC picture. And then LDH is quite markedly up with a high reticulocyte production index. So in other words, suggestive of some degree of hemolysis there. Here's his X-ray. It's quite rotated. It's basically normal. I think some of this is mediastinal just shifted because of this direction of his X-ray. Not a lot there that was found. And then his abdominal X-ray, for what it's worth, because he came in with his vomiting and diarrhea. You'll see how happy radiographers have left his shirt on. So you can see a button there. It's not in his abdomen, it's outside. Suggestion maybe of a liver pushing some stuff around, but not a lot else there either. And then abdominal ultrasound, which is actually done a little bit later in his course. I'll show you later where, but it was sort of about a week later because it took a while to get it. Liver was enlarged, so 20 centimeters on the right lobe, in the mid-clavicular line. A little bit of simple acidic fluid in the pelvis. Kidneys were fine. His spleen was normal, but it was sort of upper edge of normal. So it's about 11 centimeters where they noted it. Remember, we couldn't feel a spleen, but it was dull and trough space. So somewhere on the borderline of splenomegaly. And then his tests. So malaria test was done rapid and then the smear. Rapid test came back negative, but the smear was positive for the ring forms of malaria parasites. That's the report. And so initial thoughts about that maybe. And then so just doesn't need to be a long thing, just sort of anything that strike you at this point, Judy, and then we'll move on to, because there's one other point I want to stop at before we hand it over to the NICD.
Okay. Well, I mean, I don't know if I must go straight towards that malaria or go through the things I'm thinking, because there is obviously something they are seeing, but that doesn't mean there's not other stuff going on, I guess. So, I'll just quickly summarize. 25-year-old man who sounds HIV negative, has at risk from an environmental exposure point of view of a lot of parasitic, possibly bacterial, as well as viral infections, a whole lot of things. I just wanted to see if I had any. So, yeah, what part of the year was this that he had been there, and was it now? Although I'm sure it's some all-round malaria area.
So this was the end of May he came to see us.
So he'd been there earlier in the year, so towards the
Been
end of
in
summer
April,
anyway.
yeah. So sort of the end
Oh,
of March to sort of end of April, he had been in that region, and then he came to see us about a month later.
but I'd probably need to see a map, a malaria map, to see what kind of time of year. But it's probably pretty much all the time, depending on the rain as well. But risky for malaria. I just wanted to know if he. Sorry, did he have any rash on examination? It wasn't mentioned, but so I assume
No
there
rash.
wasn't a rash, no rashes. Okay, so he has got a bicytopenia. He's essentially presenting in borderline septic shock. I'd say he's got sepsis with multi-organ dysfunction. He's got liver dysfunction, renal dysfunction. Still sounds like he's CNS sounds like it hasn't been too affected. He doesn't sound encephalopathic. He's definitely seems septic with a raised CRP, high ferritin. Like you said, that RPI is up, so that is suggesting some mild hemolysis with a reactive marrow. And platelets, I gather those are true and not clumped. And with a raised LDH and AST also suggesting hemolysis. So, I mean, parasitic, yes, first on the list would be malaria. There is still a possibility he could also have typhoid, leptospirosis. I suppose syphilis is always worth excluding. I mean, there's numerous possibilities for bacterial infections. Those are probably my top ones. You could have a viral hepatitis, CMV, EBV. But with the malaria negative, I just wanted to know, what was it, a specific rapid test for falciparum or
Yes,
for
it was. Sorry, yeah. So our rapid tests are all falciparum specific. Yeah.
just falciparum? So the fact that they still saw ring forms suggests that it could be another malaria, one of the others, ovale or malariae. Vivax is the other option, I guess. He has previously been in Zimbabwe, so that's what I have at the moment. I don't know if seeing the smear would make a difference, or what the comment on the smear was, if there was anything else.
So his
So,
last travel outside the country was 2018, according to him.
and he hasn't been sick since, and this was this year.
Yeah, last year's actually. So this is 2024.
Okay. Okay, 6 years since, so that's unlikely. But he certainly is in a malaria area. So, well, obviously we want to know, we would probably repeat the malaria rapid test. Was that already repeated? But was it done correctly? Was it expired? Did they wait the full amount of time, the 15, 20 minutes to read it? Yeah, I wanted to make sure that's not a false negative malaria test.
Cool.
Yeah. And okay, so obviously I'd want blood cultures. He would probably be started on a broad spectrum antibiotic like augmentin, or probably ceftriaxone. Yeah, I'm not sure if they did other studies like hep studies, syphilis, you've done the HIV, probably maybe a urine MCNS as well. Yeah, people keep putting things, I'm trying not to read them. the suggestions.
Okay, cool. I think that, I mean, that's a good start. So, I mean, I think the thing which you're alluding to, you know, is there's a weird thing here, because if this is true, then you know, the rapid test is very sensitive. So either if the rapid test is done well, then this may be non-falciparum, but we don't have really non-falciparum in South Africa much, right? You know, almost at all. And also, you know, the patient hasn't traveled a while. And if it's non-falciparum, it's also quite severe, you know, this condition. So I think
Yes.
you're right,
Yes,
and you're
yes.
on all the right tracks, you know, in terms of, you know, let's repeat the test, let's have a look at the smear, agree to all of those things. The ID doctor who saw this patient first also had the wonderful thought, this is Lauren, I'll give you credit, of this sort of HRP2 negative falciparum malaria. In other words, you know, this false negative rapid test come back, could this be falciparum? Now that hasn't been seen in this country, but it's been seen elsewhere. I think it hasn't yet been seen in the country still. Our experts from NICD can chip in a second, but you know, but it's certainly, you know, it's not impossible. It's been seen elsewhere. So we started on artesunate. I think that's totally reasonable, and then ceftriaxone as well, because of course one component to maybe explain the severity was that there's some other concomitant infection that's gone on. In other words, you know, they got some non-falciparum malaria maybe, but there's some other bacterial component. So it was given both those two things. Because the rapid was negative, the smear only came out the next morning, and so artesunate was only started on the second day, you know, after admission. But you can see there it didn't really work. I think that's a good way of looking at this slide. So hemoglobin kept falling, and the platelets kept falling, and sort of were down to 48 from 62. And the creatinine kept getting worse as well, and markedly up. And in fact, on the fourth day, with a creatinine that had gone up to 500, and you know, despite artesunate therapy and all the rest of it, they actually started dialysis, and he became fluid overloaded on that day too. So it wasn't obviously just the creatinine figure, which is high but not astronomical. It was also he became overloaded. And as you know, in malaria, we definitely don't push fluids because of the risk of ARDS, and so you know, this is absolutely right timing to start dialysis, because you can't, you know, it's not like you can pump a bunch of fluids in and see if it works. So he became fluid overloaded, developed pulmonary edema, and they started dialysis. Any thoughts at this point? Any other thoughts you want to add?
I'm going to kick myself. I don't like looking at what people put on, but obviously my other thought was babesiosis. I don't know if we're in the correct area of the world for babesiosis, and I was recently on the course with Charlotte and John, and there was this other weird one that causes these ring forms, and for the life of me, I can't. It is another, probably apicomplexan or some parasite that goes inside the red cells. I just can't remember its name. And I also gather they're not going to necessarily respond to the artesunate. I mean, my other thought would be you were giving IV artesunate. Hey, we weren't relying on oral, and he wasn't absorbing it
That's right.
correctly.
Yeah, intravenous. Yeah.
So
Yeah,
it's
so
another
we've
funny.
never had a babesia case in South Africa, but
No, it's this other one.
it's not the quite right area, if you know what I mean. But you know, it's a first
No.
for everything, I guess. But it's a lovely thought. I think that's
Lovely thought.
a nice way of going. Okay, so I mean, we you know, we have our sort of weekly grand rounds, and when it was being presented, it bugged us because this didn't really fit very nicely, this case together. So we actually asked to see the smear. We went down to the lab, and the hematologist very kindly gave us the, you know, use of their microscopes. We had a look at it. And it just looked a bit weird. So this is the email I sent Charlotte, who's going to take over, I think, in a slide's time. And just said, basically said there, this is this weird case. I said unclear travel history because that was true at the time. We got this most of the history later. And I said, we went down and cast our inexpert eyes on the slides today and we're a bit stumped by the speciation. And then I said, please, you know, let us know what you guys think this sample's on the way.
Wait, I'm
you know,
sorry. I think it's something like anthosoma or something, but now I'm going to shut up because that's the word I remember.
You're definitely on the right track. Okay, so this was where, you know, just kind of bugged us. This wasn't fitting together, so we sent the thing to the NICD, and I'm going to hand over to Charlotte to tell us what she saw.
Thanks, Jeremy. Thanks, everyone. Can please, am I audible?
Yes, absolutely. Yeah.
Okay, great. So just right off the bat, gold star for Judy. And amazing that she remembered the cases we discussed recently. But so just to start off, thanks to Jeremy and the team, and actually to all colleagues on the call who reach out to us at the NICD and refer cases to us such as this, you know, either from the clinical perspective or from the laboratory perspective. So often when we get these referrals, and this is why sometimes it's, you know, it's better to call us or email, because then we can discuss a little bit more about exactly what's been discussed here. What's the travel history? What are the other likely exposures? What's the clinical presentation? And then to also ask all of these questions that Judy has been asking. So, you know, how was the test done? What rapid test had been done? You know, just interrogate a little bit more about what actually was seen on the smear, because this all of it helps direct us further, helps direct further testing at the parasitology reference lab. So then often what we'll also do is, whilst the specimens are on the way, we'll look to bring up the actual report and see what's been reported at the sending laboratory. And then often we'll may repeat the rapid diagnostic test. So we have the Plasmodium falciparum specific test and we have the pan-malarial test. So depending on the situation, we'll repeat one or both. And then we often ask for the smear that was made to be sent to us so we can look at the smear that was reported on, and where possible, fresh EDTA so we can repeat smears. And then where necessary or indicated, we'll then go on to further testing like molecular testing. We have real-time PCR, conventional PCRs, we can do sequencing, and we also have access to the NICD sequencing core facility to do any further molecular testing. Next slide, please. So here we have the part of the initialist report that was sent out, and you can see on the peripheral blood smear, they reported ring forms of malaria parasites that were seen, along with all of the other morphology of the red blood cells. And they saw a left shift with toxic granulation, reactive lymphocytes, and they said platelets were decreased in numbers. But in the comment, which is a little bit also confusing, they said no platelet clumping. They were looking for any malignant cells, no primitive cells or blasts, and then no malaria parasites. And then they carried on commenting, and they said evidence of infection. And then, like we said, as Judy had asked, what RDT did they do? And they said negative for Plasmodium falciparum only. So that was really important to see if they had described any kind of morphology other than ring forms, and they hadn't. Next slide, please. So then at the NICD, we repeated the rapid test, both the Plasmodium falciparum only and the pan-malarial, and they were both negative for malaria antigens, so confirming what was done at the base lab. And then we did a malaria PCR. So this is an accredited real-time PCR, and it can detect Plasmodium falciparum, ovale, vivax, and malaria, as well as nosei. And that was run, and we run it in duplicate, and that was negative. And we also look for inhibition, and there were no inhibitors, so that was negative. So then we looked at the smear, and we couldn't see parasites that looked like malaria, but we did see parasites. We counted them, and we did a percentage parasitemia. And then we described what we had seen, and I'll show you some images now. But we were seeing parasites within the red blood cells and outside of the red blood cells. We saw some forms that looked like tetrads, and that looked morphologically quite similar to Babesia species. And of note, we didn't see any malaria pigment, so no hemozoan observed. Next slide, please. So we did a thick smear, stained it with Giemsa, and here you can see, you can't see the red blood cells because they've all been lysed. You can see the background white cells, but I think I'm hoping you can appreciate that in between, you can see these little pink dots and blue cytoplasm. So quite a lot of them lying in between, and these are the parasites on the thick smear. So we're definitely seeing something. And can look very similar. Babesia and malaria can look very similar to this on the thick smear. So you can't really say anything other than parasites detected. You're going to have to do a thin smear to try and describe the morphology and see what's going on and look at the characteristics of the red blood cells that are parasitized. Next, please. So here we have in succession 3 different fields that will come up. A thin smear Giemsa, looking under oil. And so here you can appreciate that there's these parasites within the red blood cells, and you can see that the red blood cells that have these parasites are more or less the same size as the rest. And here you can notice quite a lot of different trophozoites within one red blood cell there. And they look kind of a little bit fleshy, not very delicate, not very ring-like. And then if you look to the other side, the extreme left-hand side on the top, you can see what looks like a vacuolated form. So that's very atypical. And so none of these look very typical of malaria as we know it. Next slide, please. So if we scanned along and we looked at others, and here we can see this slide shows there's parasites and multiple parasites within one red blood cell on the top, but you can appreciate at the bottom, you can see these parasites, organisms lying outside of a red blood cell. So they're intraerythrocytic and extraerythrocytic. They're quite pleomorphic, so they all don't look quite the same. Some look quite thin and maybe more stringy, and some look more fleshy. And they seem to cluster together at certain parts of the monolayer of the blood film. Next slide. And here I think we're trying to demonstrate again similar morphology, but you can appreciate that in some of them, they seem to appear in tetrads, like the one on the extreme left. There's 4 of them within the red blood cell. But here you can really appreciate the pleomorphic nature of these organisms. So they look quite different from each other and different within the red blood cell. So putting all of this together, there's pleomorphism, multiple parasites within and outside of the red cells. There's lack of malaria pigment or hemozoin, and there's some of these vacuolated forms. So quite, and some that may look like tetrads. So again, very much not very typical of malaria, but leaning more towards what has been described for Babesia. Next. And we can't see anything in the background, so nothing in the white cells. There's a question about anaplasmosis, so nothing in the white cells. The parasites are in the red cells and outside of the red cells. So then we did a PCR and a conventional PCR. We have so based on that morphology, we did a pan-pyroplasm PCR. We've got a product and we sent that for sequencing, and this is the result that came back. So well done, Judy. It's Anthemosoma garnami. And that's the organism that you remember that's similar to Babesia and clinically can present like malaria. And so if you look at this phylogenetic tree, you'll see in the red box is the isolate in question from this case. And if you look at all of the other, from the bottom to the top, you'll see closely related to Plasmodium, to Babesia, to other pyroplasms like Thaleria and Cytoxoon. Next, please. So what is Anthemosoma? So the phylum Apicomplexa, and well done again, Judy, for remembering that, is a large group of parasites. And this phylum includes parasites like the Plasmodium species that cause malaria, but also other parasites that we are familiar with, like Toxoplasma and Cryptosporidium. So if you look at the green shaded area, on the top, you'll see that in the hematozoa, there's the Hemosporidia and then the pyroplasm group. Next, please. So within this phylum, you have this order Pyroplasmida that contains Babesia, Anthemosoma, Thaleria, and Cytoxoon. Next, please. And what is known is that primary vectors for these pyroplasmids are mostly exodid ticks, and they mostly infect a number of wild and domestic animals. Next, please. And that's a picture of the ticks in question. So if you look at what's known, that's the hard ticks. So if you look at what's known in the literature in terms of pyroplasm infections, they're mainly diseases of livestock, companion animals, and right at the bottom, humans. And these are the different hosts, the diseases that they can cause, which agents are implicated, and then where in the world you would find them. So if you just run your eye through that list, you can see that there's babesiosis in cattle, including on the African continent. There is canine babesiosis in Southern Africa. You can see the cat feline babesiosis as well in South Africa. And then right at the very bottom, if you press enter again, Jeremy, I think it should highlight that in terms of humans and pyroplasma, there's human babesiosis, which is well described, mainly from Europe and the United States. So yes, Jeremy, you're right. We haven't had any locally acquired cases of human babesiosis, but last year there was the first reported case of imported babesiosis, Babesia microti, in a patient who presented to the private sector who had traveled to Maine in the US. And the diagnosis was made in private sector based on negative malaria tests and positive parasites in the blood. Next, please. So what is anthemosomiasis? It's an erythrocytic murine parasite, first described in mice in Ethiopia in 1969. And it's the spiny mice, Acamus percivali, and you can see a picture there, really quite cute. And it's surmised that the exotic, the hard ticks are the likely vectors of this organism. Like you've seen, it's closely related to the babesids, and so they have similar microscopic appearance in the peripheral blood and likely good clinical response to the same agents, clindamycin and quinine. And so this case that's been presented was actually the second case that we had seen. The first case I'm going to talk you through now, but it likely then establishes a likely epizootologic similarity between Anthemosoma and Babesia species, suggesting the potential for this organism to cause zoonotic infections like we've seen with these two cases. Next, please. So this is the case, and it's been published in 2021. This was the first report of anthemosoma in an HIV-infected man. So the first human case reported in the world. And you can see there are the authors, including Prof. Freen. So this patient presented to an Eastern Cape hospital in 2019. It was a 24-year-old HIV positive man from Zimbabwe living in East London, and he had lived in East London for 18 years. He presented with fever, weight loss, anemia, and splenomegaly. He had given a history that 4 months prior, he had returned from a 2-month visit to Masvingo province in Zimbabwe, and that's highlighted in yellow on the map. He didn't describe having any tick bites, but there were goats and cattle on the farm in the area that he visited. And at the hospital, he had a positive blood smear showing parasites, which were thought to be malaria, but with a negative rapid antigen test for malaria, very similar to this case. Next, please. And these are the images from that patient. And now you can see very similar to the case that's been presented today, pleomorphic, multiple different red blood cells. If you look carefully, you'll see there's some that look like tetrads inside and outside of the red cells. So microscopically at the NICD, because this was referred then to Prof. Freen, a provisional diagnosis of Babesia was made, babesiosis was made, and then a pyroplasm and Babesia PCR targeting the 18SR RNA gene was done. But again, the sequencing there didn't come back as Babesia, but as anthemosoma. So this patient then was treated with IV clindamycin and oral quinine, as well as his ARVs, and did really well. And then was lost to follow-up for 14 months. Denies ever having traveled outside of the Eastern Cape in those 14 months, but when he came back, he had a recurrence of the episode. And I think he had also not been taking his ARVs. And then he was admitted and given treatment for 6 weeks, and he did well and restarted on his ARVs. So that was the first case, and the case that's been presented here today is the second. Next slide, please. So just before this case presented in June 2019, there was actually a 2018 review on this organism, and you can see the journal and the article title there. And this review is very nice because it describes that Anthemosoma garnemi was first discovered in Ethiopia, or described in Ethiopia in 1969 in spiny mice, and then again in Namibia in 1985, and I'll show you that publication in a while, and if also from 2 different rodents, but nothing since then, since 1985. And then lo and behold, in June 2019, a human case was described in South Africa and a Zimbabwean man, like we've just seen. And I included here the micrographs of the different stages of this organism in the red blood cell, mainly just to show the trophozoite all the way to the immature and the more mature Schizon stage. But you can see at the bottom row, HI, it looks very much like a flower. So anthemos means, in Greek, it means of flower, and I think that's where anthemosoma comes from, hence the flower power title for this presentation. Next slide, please. So there's also a French article from 1972 that looked at the ultrastructure of anthemosoma in the murine model. And I've included the EM pictures there. And if Monica is on the call, she'll probably tell you that what you're seeing there, the darker room on the outside is the host cell or the red blood cell, marked with the H. And then the parasite is actually in the top and the bottom, the lighter area. And you can see the parasite vacuoles marked with a V, and N for the nuclear areas. But and it looks quite pleomorphic, so different in both of these. But Monica did say to me that this article is a little, that these labeling is a little bit dodgy because she's not seeing a lot of chromatin and too many N's. So, but from our current case, Jeremy, the one that you presented, we did try to do EM, and I think Monica did send some images, but they were not as good as these ones. So I've put these ones up instead. Next slide, please.
Sorry, 1 second. Point options. Cool.
Okay, so here is in the Journal of Science from 1985. Gunders, who's South African, I think, has described in 2 different rodent species the occurrence of anthemosoma in Namibia. And what's also interesting is that there have been different scientists, including him, who've tried to infect different rodents, and they've been seemed to be resistant to anthemosoma, except for these 2. And also there've been other studies where they've tried to infect different mosquito vectors with anthemosoma and have not been successful. So what we know before these human cases from all of these publications was that this organism was described in spiny mice and or rodents living in dry areas from 2 places on the continent, in Ethiopia and then in Namibia. So these are the 2 first cases described in humans in Southern Africa, other than Namibia. Next slide, please. Okay, and then just to say, because you mentioned babesiosis, that there's obviously animal babesiosis in Southern Africa. There haven't been any locally acquired cases, and I'm sure Jeremy will bring up an article that was published, I think, in the early 1990s, and we can talk about that, where they described 2 cases of babesia in Southern Africa. But what we know from what we know from pyroplasma infections and babesia mainly is that the clinical symptoms are similar to malaria. Severe infections seem to occur more often in the immunocompromised, the elderly, and the very young patients. That mild to severe hemolytic anemia is more common, and that recovery is slow, and malaise and fatigue may persist for months. Okay, and I think I'm going to stop there. Thanks, Jeremy.
Sure. So I'm going to maybe just present the tail end of the case just because, and then I'm going to open it up because of Monica's on the call and I'm sure she wants to chip in and John's as well. But let me just continue with the case for now and then we'll open it up at the end. So initially the NICD very kindly, so I mean basically the day after we sent it, so it got to them and they had a look and they phoned and said, we think this might be babesia. This is before the molecular results were available, but morphologically. The preferred regimen for babesiosis is atovaquone and azithromycin, but we don't have atovaquone standalone in South Africa. You can't buy atovaquone by itself. For those of you who remember your malaria prevention, there's atovaquone preguanil, which is Malinil. And so in theory, you could have used that, or we could have used that to get the atovaquone. The problem is you get preguanil with it, and there's nothing you can do about it, clearly. And is that a problem? Well, in most patients, it probably wouldn't have been a problem. The atovaquone dose for babesiosis was 750 milligrams. So that would be about, well, it would be, I think, 3 tablets. But then the preguanil dose, twice a day, the preguanil dose would be 300 milligrams because it's 100 milligrams in each tablet. So you'd get it it's on the high side, but it's not astronomical. I mean, if you use atovaquone and preguanil as treatment of malaria, and we don't in this country, but you could, the dose there would be about 400 milligrams in the day. This would be 600, in other words, 300 BD. So it's high, but it's not astronomical. The problem is it's renally excreted. And this guy had severe renal dysfunction. Remember, he was on dialysis. So preguanil is contraindicated actually if your GFR is less than 30. And by the time you end up with no GFR, basically on dialysis, the rate is astronomically high. It's something like 10 to 15 times the area under the curve of a normal dose. In other words, this is incredibly high levels of preguanil that you'd give if you were giving this individual here atovaquone preguanil because of his renal failure. There's lots of toxicities, hematological toxicity, liver toxicity, central nervous system toxicity, you name it. And it's really bad. So the packaging says don't even give it less than 30, but this guy's GFR was basically 0. So we couldn't. I'll give you just one other thing. If you're using it for prevention, so not treatment, you would take 100 milligrams a day of preguanil, so atovaquone, but preguanil with it, and 100 milligrams of the preguanil component. So 700 milligrams in a week, in other words, 100 milligrams a day. The CDC say if there's no other option for malaria prophylaxis and this patient's renal failure, you should give 50 milligrams a week, in other words, 1/14th of the dose. In other words, just to give you some idea of how toxic the levels would be if we gave this guy the atovaquone preguanil. So that was out. Alternative is clindamycin and quinine. And in theory, we have these, but in practice, we don't. So no one in big inverted commas stocks quinine anymore because of a very successful program to say, for goodness sake, this is not the recommended therapy of malaria. Get with the program, ditch your quinine, and move on to artemisinin. So there's certainly none at our hospital. We got our pharmacist and ourselves to phone around colleagues, and some of the colleagues are on the call who I phoned, and then the pharmacist phoned many of the others. There was none at Barra, there's none at Charlotte. There was, in fact, none at any state hospital in Gauteng. Our pharmacist was on the phone for about 2 hours, phoning individual pharmacies to check. And you can imagine this guy's busy really dying in front of us. So then we spoke to the person who knows absolutely everybody, Professor Lucille Blumberg, I think he's on the call. And with the help of AI, she transformed into a superhero, as you can see her going now. There she goes with her cape. There we go, like a true superhero. And I promise that's not actually a video of her. Sorry, Lucille, in advance. And she sent out a WhatsApp to basically every single person on one of the groups who's involved in any of the private sectors across the country, and started getting a flood of phone calls to her phone with people saying they're going to look quickly and see what they've got in their pharmacies. And that we had people get sorry, Lucille, in advance. We had literally, I think, Lucille, you probably had about 40 phone calls afterwards and 40 messages coming through with everyone trying to help. Really great, huge team effort from around the country. And then it turned out that there was some just on the road in Mill Park Pharmacy that was their last bottle, and they had 2 bottles, but these were both the last ones that they had, and they were both about to expire. In fact, they were throwing them out the week afterwards. And they very kindly said that we could have them because they were going to throw them out anyway. And so we drove there, collected this. That was a picture at 5 p.m. on the day after Lucille had been on the phone for about 2 hours. And we managed to get quinine for this patient. We obviously had the other component, had the clindamycin. And so this patient got his first dose that evening. And that was day 6 effectively, because in other words, we sent the sample off to the NICD, I think on day 3 or 4 or so, or two or 3. But then of course it took a little while to get, no, I beg your pardon. We sent it on day 4, and by day 5 we had the Babesia story. All right. So no one obviously knows how to treat this when it's in a human, because this is the second case, so no one knows. But probably also works the same as Babesia works, because it's very closely related to Babesia and seems to work the same in vitro. So we gave both for about 14 days. Again, no one knows the duration, but I just remind you from babesiosis, if you're immunocompetent and you have a good clinical and microbiological response, the usual duration is 7 to 10 days. If you're immunocompromised, though, there's a higher rate of relapse. And that was interesting because, of course, that was the first case, was an HIV positive individual, and he did relapse. We didn't have enough quinine to give for nearly 6 weeks because we had what appeared to be the last amount in Gauteng at the time, but it was enough to give. We gave him for 14 days. Obviously, a bit of a thumbs up on this. But the good news is, obviously, that was also in conjunction with seeing his response. This is day 6 of admission, but day 1 of treatment. He gets quinine and clindamycin, and you can see that the platelets started to rise. By the next day, it was already going up, and it kept going up. This is day 18, so at the end of treatment course, basically, it was entirely normal. The CRP kept halving, and the bilirubin for the liver got better. He was also feeling a lot better and looking a lot better. The smear actually cleared, at least an hour read from within the hospital from day 2 of treatment, which is quite quick. There's a little bit of activity artemisinin have at the sort of doses we give, so maybe that contributed a bit, but certainly didn't seem to help until we gave him the quinine and clindamycin. But the smear cleared fairly quickly. His renal function, by then he'd already had acute tubular necrosis, so in other words, he wasn't going to recover as quickly as the rest of his bloods did, but it did improve. After about day 4 of treatment, they were able to stop the dialysis at least, but obviously his creatinine took a long time to recover, but it did. Over the next about 2 weeks. So by the time he was sent home, about 14 days later, his creatinine was 122, which is way better, although not back to baseline. But he was seen a month after discharge, and it had completely resolved. So it had gone all the way back to baseline. GFR there is perfectly normal. And then for what it's worth, we thought just at the end of his treatment, let's repeat an ultrasound and see. And in fact, both the liver and the spleen had gotten smaller. In a really kind of useful way. So this, unfortunately, was day 7 after treatment was started, because it was the long delays in getting an ultrasound where we were. So in fact, we don't have a baseline ultrasound, which may have been even bigger. But nonetheless, you can see both the liver somewhat and certainly the spleen got smaller on treatment. So you actually can see a response, at least if we believe this. And I think we could, because it clinically correlated as well. His liver seemed to get smaller clinically as well, and so did the spleen. That this really, within 2 weeks, you could certainly see a change, which is quite interesting. So he was given a follow-up date and he missed it. Unfortunately, he did weirdly come to medical outpatients department. He was seen by an intern who didn't understand the case and sent the patient home, but managed to do at least a UNE, so we knew he was getting better. And he's not been contactable ever since. He's gone back to his ways, increasing the GDP of the country indirectly through gold. And that's as far as we managed. I did manage to get hold of a family member of him about 6 months later, who said that he was doing fine, but we've never seen him. So I hope he hasn't relapsed. He knows where to come if he can. In theory, if it behaves like Babesia, he shouldn't really, because he's immunocompetent, unlike the first person. But obviously, we don't know. There's a lot we don't know about something like this when there's so few cases. So I'm going to end there and open up and just see if others have anything they want to add. But really, just one really important part of this case is to thank a huge amount of people. So I'm presenting this, but I mean, this was huge team effort with myself and Lauren and Sharon from our team. And then the NICD's team were incredible. So Charlotte's on the call and John is on the call, Bhavani and John Ratabani, who's involved with the case as well, and their team. And, this is not a diagnosis you can make in many countries around the world, because you don't have the expertise that the NICD does. So really, thank you to them and congratulations to them, because this sort of thing is, it would have been put down as an atypical malaria in most places. Professor Bloomberg, the superhero, who found us some quinine and really helped pull the case together. And then thanks to Milpock and Mandy Tupkin, especially, who managed to get us the last amount of quinine in Gauteng, what it felt like. Anyway, thank you very much. And I'm going to pause there and stop, but I just wanted to open, see if Charlotte or John or Monica had any other comments they wanted to add.
Thanks, Jeremy. I'll just go first. It's Charlotte here. So just to say that in November 2024, we got a similar call from our colleagues in the lab in Mpumalanga and NHLS. Also a young, mid-20s Zimbabwean national who was involved was a Zama in illegal mining, also with a discordant malaria result that turned out to be anthemosoma. So there are 3 cases since 2019 that we know of.
Wonder if it's the
And so just
same.
to put it into context, why we don't see, oops, sorry, my cat just broke my lamp. Why we don't see more cases is because probably because of the rodent hosts that like certain conditions, but I'm pretty sure we may be missing more cases of pyroplasma in humans because of the overlap of malaria and animal ticks but mostly the clinical presentation with malaria. So just to encourage everyone, if things are not fitting, and for number one, the most probably common reason for having a false negative RDT is probably because of operator error and things that we've discussed. You asked about surveillance for HRP23 deletions. So from the surveillance that's been done in South Africa, there haven't been any detected to date. But we have to be on high alert and vigilant for people coming from other countries or infected in other countries. But it's most likely that it's possible that these are misdiagnosed as malaria. So if you have any queries, don't hesitate to reach out. Thanks.
Charlotte, that third case, I'm hoping it's definitely a different person, right? Different name.
This is, Jeremy, the PRL team and I, we went through it. We looked at the names because it was the same age. It was a Zimbabwean national. It was a illegal miner, and we all had that moment where we all ran to the book to check the names to make sure it wasn't the same person and it was a different name.
That's so interesting. I mean, in the same region of gold mining. I mean, I wonder if because of the same. Yeah, fascinating.
So we did then do some further investigation. We've reached out to the South African National Biodiversity Institute to think about screening ticks for anthemosoma and also to try and make contact with some other colleagues working in the field. We just haven't. That's still in discussion.
Incredible. John, you've got your hand up.
Thanks, Jeremy, and a wonderful case presentation. Thanks, Charlotte, as well. Charlotte did mention the 1990 letter in the SAMJ about 2 cases of babesiosis diagnosed in South Africa. And that publication's always cited as, when babesia in Africa comes up for discussion. But it was purely morphological on blood smear. And we looked into this a while ago. Fortunately, we still had some material from one of the cases, in fact, from both, in the form of blood smears. So one actually turned out to be Plasmodium falciparum malaria, so not babesia at all. And the history there fitted perfectly with malaria. The patient had been, I think, to Vic Falls in the few weeks before getting ill. So we can cross that one off for sure. The other case is more interesting because the slides were referred from Namibia, and we were unable to amplify any malaria sequences or pyroplasm sequences. So we're still not sure exactly what that is. The amount of material was very, very small. Genetic material was very small, and we may just not have had enough, or it may have been too old and degraded. But the fact that it came from Namibia, where Arnon Gunders found the infection in rodents, as Charlotte mentioned, yeah, there's still a question mark over that. Could that be anthemosoma? We'll never know, but there's a possibility. And I think it just illustrates the fact that non-malarial pyroplasms are probably often misdiagnosed as malaria. And if the patients don't do well, then it's put down to severe malaria. So it's a matter of keeping an open mind, of course.
I mean, John and Charlotte, do you think that? I mean, I guess the molecular age is required to diagnose anthemosoma. I mean, I'm assuming there's no morphological difference on slides between Babesia and anthemosoma, but if this was, I mean, we found 3 then in the last, say, 2 or 3 years. That seems like there might be a sort of increase. I mean, do you think it's something to do with the climate or maybe the mining, the illegal mining in a particular region? Or, I mean, do you think I mean, guess where I'm coming is, do you think it's all just detection bias? Are we just finding more, or do you think there is something that's changed in the last, decade or so?
Jeremy, I think it's difficult to say, although tick-borne diseases are regarded as expanding their geographic footprint because of climate change and conditions becoming more suitable for ticks and therefore tick-borne disease transmission. But I think these are so rare that we don't really know. I guess we'll see if it becomes more common as time goes on.
Yeah.
And just to add that, Jeremy, it may be people going into environments where they were not exposed before, like these zamas that live quite rough in the fields and all of that. So who knows? But also just morphologically, it's very hard to distinguish Babesia from anthemosoma from the few cases that we've seen. In fact, when your case came through and we'd all had a look at it, I think we were taking bets as to what it may be. So I think one had a thought it may be Babesia microti like you see in the rest of Africa. Someone else thought maybe anthemosoma, and I was hoping for something novel. So I don't think we've seen enough yet to try and see what the nuanced differences are morphologically.
Got it. Yeah. John?
Just one other point. Those beautiful flower-like images that Charlotte showed, those were the stages in the rodents. We don't see those. We don't see those flowers in the human cases because obviously it's the wrong sort of host for all the morphology to show up as it does in the rodent.
Cool. Monica, yeah.
Thank you. Sorry, just comment following that with Profreens. When I was looking at the specimen, and I had no clue what I was looking at except red blood cells with things in them. So I was really excited to find that paper that Charlotte used the image from, which was 1975, and quite clearly, as happens to many of the people who first look at things, they didn't know what they were looking at either. So if you recall, I can put the reference on the chat, but there were lots of lobes of clear-looking areas inside what was obviously the parasite form, which they labeled as nuclei, which I thought is because they had double membranes. Oh, there we go. These, sorry, I don't have a pointer, I'm pointing with my, yeah, but all those little clear areas are actually not nuclei. You couldn't possibly get a fragmented nucleus like that. And what I've subsequently found out is that there actually are mitochondria, which are acristate. So only once these develop do you actually see the typical mitochondrial structure with the inner membrane forming the folds with the respiratory enzyme. So I thought that was really quite fun, because when you do start looking at things, it's really difficult to know which end of what you're looking at. But it was just by the way. And that, yes, you have to be very careful of not just which host you're looking at, but which stage of development you're looking at. Thank you.
Oh, that's fascinating. Thank you. Just really briefly, just to the chat, Professor Musa is asking about the mechanism of relapse. Does anyone, so in Babesia, I guess, and this too, although I guess we don't know much about this organism, but how does the relapse occur? Does the organism hide somewhere and then reemerge, or what is the thinking?
So I think it's probably not relapse in the sense of relapsing malaria. I think in that first case, it was probably in short duration of treatment, or not long enough, and possibly the HIV had something to do with it. That's what I surmise, but I guess we don't know the full
so
life cycle. We don't know the full
full.
replication cycle. We don't even know which tick is the host, and so there's still some questions around the biology of this parasite.
Mm. And then Diana Hardy's saying, does this provide an indication for having some quinine in South Africa? I mean, someone should have quinine somewhere. It comes up occasionally. I mean, it's clearly not a rationale, given the infrequency of the cases, for it to be broadly stocked, but it's definitely not a drug we can completely throw away. And as you say, we never know. Maybe this particular focus of illegal mining is going to provide us more cases in the next year.
Yes, I think we
So
should
Julie,
ask Milpark to keep a stock, please.
Yes.
and Lucille had put me on to
Sorry, yeah.
someone to try and coordinate just finding out where the quinine stock is in the country to keep it at a central point. And so I did reach out to her for that as well.
No, that's really handy. Yeah, definitely worth keeping around. Okay. Well, thank you very, very much. I mean, we had fun presenting this case, and thank you so much to everyone for sticking around. And really, again, thank you massively to the NICT team, especially, and Professor Bloomberg as well for the quinine hunting. But this is really, many people have made this such a, a really good case to present, but also, such a nice outcome for the patient. I mean, he really was almost dead by the time we got him his quinine, and he made an entirely full recovery. And we just hope he doesn't relapse. And if he does, at least he knows where to come.